Welcome to our 2020 Women and Parkinson's Disease Symposium, co-hosted by the Parkinson Foundation and the Medical University of South Carolina. I'm Dr. Vanessa Hinson, and I will be the moderator for today's program. So throughout this morning, we will learn some key facts about women and Parkinson's disease. We will listen to women who are here live with us at the MUSC stage, share their experiences, and interact with all of you throughout our question and answer and breakout sessions. We do have time for a restroom break that is scheduled, but of course you can get up anytime and move around since you're enjoying this program from your house, so feel free to do so. Our general session will be recorded, but our breakout sessions will not, in order to preserve everybody's privacy, and the panel will not be recorded either. So if you have any questions, please use the chat icon on your screen and type in your questions. We will address them to the best of our ability during the question and answer session, and then you can also chat directly with your breakout session moderators. Now, before we get started with our presentations, I would actually like to learn a little bit more about you and why you're here today. So we're going to launch a question on the screen, and you take just a few seconds to answer it. So the question is for you to please share why you're here today for the Women's Symposium, and you just check what you think applies to you. Do you want some alone time with your husband? Maybe your boxing class was canceled and you suddenly had free time to fill. You might want to meet other women with PD, even if it's virtually, or because you believe there are important gender differences between women and men and how they experience their Parkinson's disease. So we'll just give you a few seconds to hit the right button there. And there's no wrong answer except for maybe one. I see the answers are coming in. See what everybody's thinking to get us going here throughout this morning. So I'll let you all see the results. The vast majority of you are here to learn exactly what is different in the way that women experience their Parkinson's disease. And because some of you would like to meet other women with PD. And you know, these days, a lot of boxing classes get canceled because of the pandemic. So I can see why some of you might have some more free time than usual on their hands. So what we will do now is point our attention to our keynote speaker. And I would like to take just a minute to introduce her. It is my pleasure to welcome Dr. Christine Cooper on stage now. Dr. Cooper is a board-certified neurologist with a subspecialty in movement disorders. Dr. Cooper obtained her medical degree from the University of Florida. She did her residency at Beth Israel and her fellowship training at the University of Pennsylvania. And we are very fortunate to have her here on faculty with the Movement Disorders program at the Medical University. And I'm introducing her as a fantastic doctor and a great friend. So please take it away, Dr. Cooper. We'll let you take the stage right now.
Thank you, Dr. Hinson. And I'm happy to be here with everyone today to talk about women and Parkinson's disease. I do want to take a brief moment to thank our sponsors that help make this event possible. Those include the companies here, Amneal, Supernus, Acadia, and Kyowa Kirin. So today we have a pretty clear objective of discussing women and Parkinson's disease. We're going to talk a little bit about how women have been underrepresented in research in general. And we're going to discuss specifically the differences between men and women in regard to risk factors, symptoms, treatment, and overall care for Parkinson's. So, of course, no one had to come to a webinar today to know that men and women are different. However, we do need to go over just how different women and men can be in regard to medicine. So, a very brief 1-minute history of how women have been involved in research throughout the last 50 years or so. So, I will say, even before we get to research, that much of medicine was learned, the basic physiology, based on medical students and men. So a lot of what is in the textbook really was based on men, with the assumption that it also applies to women. In 1977, the FDA actually barred women of childbearing age from participating in early research. In 1980s, the National Institutes of Health took the opposite stance and urged for the inclusion of women in research. In 1993, the NIH Revitalization Act actually mandated that any NIH-sponsored research account for women and minorities and subpopulations in research. And the FDA similarly rescinded their guidelines, but did not actually make any mandates with regard to women in research. It took until 2012 for the FDA's Safety and Innovation Act to come into play, which actually required special reporting to account for sex and race in FDA research. So how does this affect us in a practical manner? So an example of this is common medication use that varies between men and women. So for example, the common sleep medicine, Ambien or Zolpidem, was on the market for over 21 years before they actually approved label changes suggesting a different dose for men and women. In 2014, which was only 6 years ago, the American Heart Association finally recognized that there was different preventative strategies to prevent stroke in women than men. So we know that men and women differ biologically, not just in the more obvious ways, but also in regard to how medications are absorbed and transported, how efficient medications are, and the side effect risk of medications. Additionally, we know that men and women are different developmentally and socially, which often affects their response to treatment and the care they receive. So, the point of sex-specific research is that everyone benefits. We all do better when we can tailor medical care to individuals rather than the whole population. So, on to Parkinson's. So who has Parkinson's in the US? Roughly 1 million people. You can see in this map that it's estimated that roughly 10,000 people live in South Carolina with Parkinson's. And 60,000 people are diagnosed with Parkinson's each year. It's a new diagnosis each year. We know that it differs between men and women. So women actually have a lower risk of Parkinson's. Roughly 2 women for every 3 men are diagnosed with Parkinson's. But it also differs in terms of race. And you can see in the graph here that for all the races, men are still more likely to be diagnosed with Parkinson's than women, but there are differences between. So we took a few minutes to look up some local research here. So roughly 2,200 people with Parkinson's are followed by our movement disorder specialists within our Center of Excellence here at MUSC, and about 38% are women. So that fits squarely within the 3-to-2 ratio that we expect in Parkinson's. We do know that age is a risk factor for Parkinson's, which we'll talk more about later. And you can see here that about 20% of our patients are under the age of 65, 40% between 65 and 75, and another 40% over 75. So, importantly, even though we know that women have a slightly lower risk of Parkinson's, women live longer than men regardless, with or without Parkinson's. So it's really important that we do all we can to ensure that they receive the best treatment for their lifespan. So we're going to move on to risk factors. Now, whenever we're talking about risk factors, it's very important to make a difference between association and causation. So just because something is associated does not mean that one causes the other. This graph is a slightly black humor attempt to portray that even though ice cream is sold at higher rates between May and July, and murder rates also go up from May to July, does not mean that selling or eating ice cream causes people to commit murder. So, with that rather bleak example in mind, we'll talk about biological factors that are risk factors for Parkinson's. So age, increasing age does increase your risk for Parkinson's. We often say that Parkinson's is a middle-age disease or disorder in the sense that many people are diagnosed in their 50s in general, which is squarely within middle age. Sex and gender differ, and we already reviewed how women are at lower risk of Parkinson's. There are genetic factors that are at play. So while we think that having a purely genetic form of Parkinson's is rare, less than 10% of all people, we do know that having a first-degree relative with Parkinson's increases a family member's risk slightly of developing the disease. And of course, there's more research into this every day now. A big risk factor for Parkinson's are what we call environmental risk factors. So these are often occupational exposures, but some common items are pesticides, heavy metals, chemicals, and traumatic brain injuries. Now, I'll remind you, we're talking about things that are associated with Parkinson's, so none of these are thought to directly cause Parkinson's, but are associated with Parkinson's. So for most people, since we think it's very rare that Parkinson's is due to one biological, genetic, or environmental factor, we think that it's more what we call a genetic or environmental predisposition that results in Parkinson's. So you have to have sort of the right underlying biological and genetic factors exposed to the right environmental triggers, and that ends up resulting in Parkinson's. So just as we know that there are some things that increase your risk for Parkinson's, we also know that some things decrease your risk for Parkinson's. And certainly this is an active area of research, but we know that physical activity decreases your risk of Parkinson's. And we know that tobacco use, coffee use, certain dietary habits are associated with a lower risk of Parkinson's. The common use of some medications decreases or seems to be associated with a lower risk of Parkinson's. And there are blood levels of urate, which is a metabolic chemical that we all have, that are higher in folks with lower risk of Parkinson's. Now, even within this list, there are differences between men and women. So for example, the lower risk of Parkinson's associated with coffee drinking is stronger in men than women. The lower risk of Parkinson's associated with the use of anti-inflammatory medications is only seen in men and not women. So this is a good example of how taking biological differences or sex is important when we talk about issues in Parkinson's. Now, one of the most obvious differences between men and women is estrogen. There's been a lot of research over the past few decades into estrogen and Parkinson's. And what we do know is that we don't know enough. So we know that estrogen may be protective for Parkinson's, but only for a small amount of time, or perhaps only in the absence of other risk factors. So we don't recommend estrogen replacement for people. And I certainly have had male patients who told me they don't care, they're not taking estrogen regarding this research. So this is an ongoing issue. So in general, we know that women are less likely to be exposed to some of those environmental risk factors that I named, particularly because of occupational exposures. They generally have less exposure to pesticides, heavy metals, and head injuries. And there's likely biological factors we haven't yet identified. So let's move on to symptoms. So for men and women, we know that the list of potential symptoms that have to do with Parkinson's is very long. So we tend to separate it into motor symptoms and non-motor symptoms. So for motor symptoms, that involves some of the common physical signs and symptoms that you notice, like stiffness, tremor, slowness of movement, perhaps some balance changes. Whereas the non-motor symptoms involve almost every other system of the body, in the sense that it includes changes in your thinking and focus. It can cause hallucinations and changes in mood, primarily depression and anxiety. It causes fatigue, it causes constipation, trouble, it can cause pain. It varies quite a bit from person to person. And luckily, it's rare for any one person to have all these items, but certainly these are a pretty comprehensive list of possibilities. Now, when they study how these symptoms vary between men and women, we find that predominantly the differences are in the non-motor symptoms. So I'll call your attention to the non-motor symptom row here. And so you'll see here that women are more likely to have mood symptoms, in particular depression, anxiety, They're also more likely to have some gastrointestinal disturbance, meaning kind of bloating or constipation. There's some controversy about whether or not women are at higher risk of dementia, although we actually don't see a difference in cognitive impairment levels between the sexes. So this may reflect the longer lifespan of women. And then pain is slightly higher in women. Men, on the other hand, are more likely to experience behavioral issues, blood pressure fluctuations, REM behavior sleep disorder or dream enactment, and sexual dysfunction. Now, you can imagine from the men perspective, this is also confounded by the fact that they are more likely to have cardiac disease that may affect their blood pressure issues. And of course, there's multifactorial issues with sexual dysfunction. So we know that in general, outside of Parkinson's, men and women differ in what other medical diagnoses or illnesses they may have as they get older. Women are more likely to develop osteoporosis and hip fractures. They're also more likely to develop rheumatoid arthritis and osteoarthritis, which of course will affect dexterity. Men are more likely to have the heart disease and atrial fibrillation, as well as colorectal cancer and COPD. So you can imagine how these comorbidities might interplay with Parkinson's symptoms to result in overall worsening symptoms. So far we've learned that women are at lower risk of Parkinson's, and we learned that the types of symptoms women experience from men can differ. So how about treatment? You know, within the Parkinson's field, we have over a dozen medications that we use for Parkinson's, as well as a whole catchment load of medications for all the additional non-motor symptoms in Parkinson's. So we know that treatment varies quite a bit from person to person, not just by sex. We also know that we have some surgical therapies for Parkinson's. And importantly, we also have complementary treatments, which include lifestyle modifications like diet and exercise, which you'll certainly hear more of both in this lecture as well as in the breakout sessions. So with medications, your physician may decide on which medications are best for you based on what symptoms you're experiencing. They likely take into account what sort of other health issues you have. One, from the standpoint that perhaps a medication can treat two symptoms, which is always helpful. And on the flip side, they want to avoid side effects. You know, your physician is thinking about side effects just as much as they are thinking about benefit. Because what good is a medicine if you're just going to have a new or different problem from taking it? And we think about age a lot with medication, again, connected to the risk of side effects. So far in the studies that have been done with women and men with medicine, in general, they do take the similar types of medicine. There's not a single medicine that's good for a man versus good for a woman. And in general, they take women and men actually take their medicine at same rates. Some of you might be a little surprised, but men and women do actually take their medicine at the same rates. And women are more likely to be prescribed antidepressants and benzodiazepines, which may fit with the fact that they do have higher rates of depression and anxiety. But men are more likely to receive medication for cognitive impairment or dementia, which is a little surprising since we said that men and women have the same rates of cognitive impairment in Parkinson's, and women may actually have higher rates of dementia, though it's unclear. Pain management is similar for men and women, which often in Parkinson's involves dopamine therapy as well. However, despite the fact that men and women take similar medicines and they take them at similar rates, women have an 80% increased risk of experiencing what we call wearing off or motor fluctuations, where you take your medicine, you might feel it kick in, but then after a certain number of hours, it feels like it's out of your system and you're back to experiencing your Parkinson's symptoms, whether they're motor symptoms or non-motor symptoms. Women are most likely to report dyskinesia as a side effect from their Parkinson's medicine. And these two often go hand in hand. We find that if your medicine is wearing off, there's a good chance you may also have dyskinesia. So we'll return to that in a few slides, but moving on to other types of treatment options. So in addition to medication, we do have some surgical options for Parkinson's. We have a Duopa pump, which basically provides levodopa directly to your small intestine, which can smooth out the absorption and smooth out, therefore, those motor fluctuations and the dyskinesia. Deep brain stimulation surgery has been shown to be safe and very effective also for treating the motor fluctuations and dyskinesias. Women who actually go on to receive DBS or deep brain stimulation report higher gains in their quality of life than men who receive DBS, which is wonderful and great. You can imagine this might stem from the fact that women have higher rates of motor fluctuations and dyskinesias. However, women are less likely to receive DBS for the treatment of their Parkinson's. And so we don't quite understand why that is, but we can have some guesses, which we'll review in a few minutes. So our last big treatment approach after medications and surgical options involves the field of complementary medicine or lifestyle modifications, which are hugely important for Parkinson's disease. They're also much more challenging to incorporate than taking a pill a lot of times. These are really exercise, diet regimens. We know that exercise is really important for both feeling good in the short term as well as the long-term progression of Parkinson's disease. We know that diet can make a big difference both in your overall brain health, but also how your medications are absorbed. We know that speech therapy can be really important in terms of helping with both the voice in terms of volume and clarity, as well as swallowing, which is incredibly important. And often they actually provide cognitive therapy as well, which can certainly be helpful. Physical therapy kind of goes along with exercise in the sense that they can provide a lot of advice and expertise on gait and balance and help you establish a home exercise regimen that's more tailored for you. And occupational therapy is incredibly important too. They can help make sure that you're able to do all those daily activities while using as little energy as possible so you can conserve your energy for things that you actually enjoy. And we don't actually know if the rate of using all these lifestyle modifications are different between men and women. So that's a big area of research that's yet to be undertaken. So why might men and women differ in terms of their use of medications or surgical options or lifestyle modifications? Well, it could simply be that women versus men are more likely to prefer one over the other. It could be a perceived risk. So certainly when we think about changing medicines or adding medicines or surgical therapies, we think of risk just as much as we think of benefit. And perhaps men and women differ on how much risk they're willing to accept. Of course, if you are dealing with something like anxiety or depression, you're maybe less likely to take risks in general. So that may also contribute to these differences. There could be differences at the rates at which physicians make these recommendations. Of course, it is not necessarily the patient who is driving care at all times. It does rely on guidance from various care providers, but certainly including your physician. So your physician may have some level of bias, which may or may not be a good thing. That involves how often these treatments are adopted. And of course, the other health conditions and comorbidities. We already reviewed how other health conditions tend to differ between men and women as they get older. And so you can imagine that they could contribute to how often these therapies and treatments are adopted. So we've talked about risk factors, we've talked about symptoms, and we talked about treatment in Parkinson's, but we need to talk about care. Now, throughout the course of your journey with Parkinson's, you should have access, or at least know someone who can direct you to access all of these different types of specialists. I don't think anyone needs to see all these people at the same time necessarily, although I will say our interdisciplinary clinic tries to combine as many of these groups as reasonable and practical within a same day. But certainly within all these fields, there are experts in Parkinson's who can really tell you how best to deal with their respective areas in regard to your Parkinson's and quality of life. So, Parkinson's patients were historically treated by primary care physicians for a long time, and perhaps only saw a neurologist if their symptoms were progressing or advancing. And then the field of movement disorders is a relatively young field within general neurology. So it's even more common for patients to seek their care from a general neurologist than a movement disorder specialist. However, we know that Parkinson's patients who are treated by a neurologist compared to treated by solely their primary care physician are less likely to be placed in a skilled nursing facility. So that alone is a fairly good reason to see a neurologist. They have a lower risk of hip fracture, which surely goes hand in hand with the first item. They're more likely to use rehab therapies, including the physical, occupational, and speech therapy that I mentioned. And overall, they have a lower adjusted likelihood of death, which that's a big one, right? There's not many things we wouldn't do if we knew that our risk of death was lower, and all from seeing a neurologist. Of course, I'm highly biased by presenting this information, but it was gathered from Medicare data. So women actually undergo a more unhappy time with the process of obtaining a diagnosis of Parkinson's. They experience a longer time period from the onset of their symptoms to their diagnosis, and they also undergo a longer time period than men from the onset of their symptoms to actually seeing a specialist, a movement disorder specialist. So you can imagine this likely contributes to why, in general, women are more unhappy with how they finally got to the diagnostic quest of Parkinson's disease. I won't pretend that anyone's happy when I diagnose them with Parkinson's disease, but certainly some folks, if they've been seeing different doctors for a longer time before they hear that, that really affects your emotional well-being for sure. So who is most likely to see a neurologist? We already reviewed why it's important to see a neurologist. The big ones being lower risk of being placed in a skilled nursing facility, lower risk of death, lower risk of hip fractures, and use of the rehab services. So in general, men are more likely to see a neurologist than women. Unfortunately, we also see a big difference in terms of racial disparity, which we see across medicine. So we really need to do a lot of work here to try to even out these numbers so that men and women of all races are able to see a neurologist for Parkinson's. So women in general, and much of this is true, I will say, in their general medical care, it's not necessarily specific to their Parkinson's, but women are less likely to see a doctor at all. They're more likely to be placed in a skilled nursing facility. They're more likely to receive outside help for their care through home health care services, and they're more likely to receive hospice care. So those last three items all involve receiving caregiving support from people outside the immediate family or living situation. When we look at nursing care facilities and women in general, we know that they are more likely than men to reside in nursing care facilities. Now, we did say that women live longer, so we have to kind of keep that in mind here. But women with Parkinson's are 34% more likely to reside in a nursing home than a man with Parkinson's, which is a fairly significant number. And in general, unfortunately, we know that residents of nursing homes are less likely to actually receive outpatient neurology care in general. A lot of times the care that nursing home residents receive really relies on the physicians who work at that facility, which don't often include a neurologist and may not include certainly a Parkinson's specialist. So why do women end up in skilled nursing facilities at higher rates than men in general? Well, there's two main health factors that have been strongly identified as potential causes. One is hip fracture. So if you have a hip fracture, you are 2 times more likely to end up in a skilled nursing facility than if you don't. Now, of course, we know that if you have a hip fracture, there's a good chance you need a lot of support in just kind of moving around in your space and getting dressed, and a lot of hands-on, perhaps heavy lifting sort of items. So this does make a bit of sense, but we know that women are at higher risk of hip fractures. So certainly this could contribute. And then dementia. Unfortunately, people with dementia sometimes have different behavioral challenges, as well as a requirement to have 24-hour supervision to ensure their safety. And so this odds ratio is actually the greatest factor, 4 times more likely if you have dementia to end up in a nursing facility. So what barriers could prevent men and women from accessing Parkinson's care? So of course, a big one is transportation. So We know that even a lot of people in our state travel over 2 hours to see us on a regular basis. So we live in a rather rural population, and much of the US lives in a rather rural population. A lot of times they have, patients have limited healthcare service availability in their area, and or a lack of quality healthcare that's in their area, which really refers to exposure to specialists and expertise within their diagnoses. Social isolation is a big factor. As we all get older, that's a big thing that we all need to keep in mind, that loneliness and social isolation increases. Financial constraints, clearly that's a big issue, both with regard to accessing healthcare providers, doctors, and all the ancillary services, but also in taking medicines and accessing medications and surgeries. And of course, limited physical mobility. If indeed you have a hip fracture, you can imagine how difficult it would be to ride in a car for a few hours to see a specialist. So, and of course, our nation still has quite a number of uninsured individuals, which is particularly important because, as we saw earlier, here at MUSC, over 20% of our Parkinson's patients are below the Medicare age. So a lot of people do have to rely on their private insurance just to access care as well. So a big factor in preventing care for women with Parkinson's and preventing care for women in general within medicine is their role as a caregiver for others. I can't tell you how many times I've heard from patients that, well, I would have come sooner, but I'm taking care of XYZ. And that was my priority, and that's, how I spent my time. Women often neglect their own health problems and certainly neglect their own access to health care because of their caregiving roles. We know from studies into caregiving in general that caregivers are more likely to be in poor health and have experienced problems getting the care they need when they do need it. So we really need to take care of men and women who are caregivers, because that is a big issue in our society as well. So women are more likely to have to pay non-family members for care. We saw that in their higher utilization of home care, skilled nursing, and hospice. They're more likely to live alone, and they're more likely to show up to their office visits unaccompanied, perhaps because they live alone. And so this is an issue because you know how helpful it is to have someone else in the room when your doctor wants to change your treatment or make a different recommendation. So something to keep in mind. So why does this matter? Well, women still, despite all of this, live longer than men. So we're talking about a longer lifespan, quality of life issues. We really need to take care of women. And women are often caregivers. So for them to do their caregiving role, we need to take care of them first. So in conclusion, we reviewed today that women are at lower risk of developing Parkinson's, slightly lower, it's about 40% versus 60% with the incidence. Women are more likely to report certain symptoms of Parkinson's. They're more likely to experience side effects of medicine of dyskinesia, and they're less likely to receive deep brain stimulation, even though it is considered a treatment for dyskinesia. They're less likely to be cared for by a Parkinson's specialist and access medical care for their Parkinson's. So the Parkinson's Foundation has acknowledged this, and over the course of the year, they developed a Parkinson's Foundation project to tackle this. It's the first in our nation to hopefully improve the health of women living with Parkinson's. And they developed an agenda, which is based on multiple meetings across the country, talking to women with Parkinson's and asking them what's important to them. They divide it into 3 main areas: research, care, and education and empowerment. And within those areas, they've identified 4 priorities, which include the encouraging research to ask the critical research questions to examine gender differences in Parkinson's, support research through the Parkinson's Outcome Project, develop a clinical shared decision-making tool in hopes that we can ensure that our care for Parkinson's is in line with the women's wishes, and education and empowerment. So sponsor an educational symposium that actually is focused on caregiver and care partners' health for women with Parkinson's, and invest in self-management resources that can help women ensure that they maintain the quality of life they deserve. And with that, I will turn it over to Dr. Hinson.
Thank you so much, Dr. Cooper. That is wonderful. And it's great to see how many facts are actually known about women and Parkinson's disease. And it really gives us food for thought to now, directly talk to women who actually live with Parkinson's disease. And that is a wonderful segment or introduction to our panel discussion that follows now, live from the MUSC stage here in Charleston. And I would really like to thank my three panelists for being here early in the morning and sharing their time with us. Let me make a quick introduction here so you know who we're speaking with. We have Virginia Pennington here from Somerville. We have Mary Thomas from Hollywood, and we have Lynn Dukas from Bluffton. So welcome to the stage. And in real life, we would hear big applause right now. So we'll just imagine that that is happening from all of you behind your laptops and microphones. So let's just talk a little bit about your individual situations. Let me start with you, Virginia. Virginia, you shared with me that you were only 43 years old when you first started noticing that your right arm wasn't swinging correctly. You were dragging your right leg when you were on a jog. You just couldn't run like you used to. You being an athlete, you wouldn't notice that. And maybe your hand was a little bit shaky. But then, just like Dr. Cooper pointed out in her presentation, it took you several years to get a diagnosis. But when it finally happened, you were still under the age of 50, and suddenly you hear this big word, Parkinson's disease. Do you still recall that moment of diagnosis and the emotions that were going through your head at that point?
Oh, definitely. I'll never forget. I guess the biggest thing at that time was get my thoughts together and figure out where to go from there. Because when I got my first diagnosis, it was not here at MUSC. But I knew that I needed more care than that. I was way too young, and I wanted another opinion. And after getting past the shock, researched and got some good answers from some local people who have been down here with both of you. And so, yeah, it was shocking. Not at all what I expected.
Who would expect that, right? At
No.
that age, absolutely.
Yeah.
And yeah, I can see that that would be a shock. Who would be prepared? But if anybody would have been prepared for such a diagnosis, maybe it was Mary. Let me give you a little bit of background there. Mary shared that her mother actually suffered from a form of atypical Parkinsonism that we call PSP, and Mary was her primary caregiver. She even led the PSP support group and had attended several Parkinson's disease support group sessions. And you told me that you kind of knew you had Parkinson's disease before any visible symptoms actually developed. What was that internal feeling like that made you think that?
I attended a lot of the Parkinson's support group meetings at Emory because I lived in Atlanta at the time because of my mom. And it was like a Zen-like moment during one of those sessions that I had. I felt that I was one with this group. They were my friends. And I didn't feel anxious, didn't feel nervous about it, just calm that I had found a group that I could be with. But whether or not that Zen-like moment came from understanding that some of the symptoms that I was already suffering with constipation, leg movements during sleep, and my mood did not fluctuate at all. It was just very stable, and that was a little different. Not that I was all over the place with my mood, but it was just very stable. And perhaps because I knew that those were symptoms of Parkinson's, that was a possibility. But I also was working long hours in my career, and maybe I was tired. Maybe I wasn't getting enough water. Used to know.
Looking back at you, Virginia, when you were diagnosed, and now that you know that sometimes, symptoms that are not immediately by the lay person associated with Parkinson's disease, you know, like tremor, for example. Everybody knows that's kind of Parkinson-like. But you were mentioning, Mary, the constipation, for example. Did you have any of those kind of more odd symptoms?
No, my biggest, I guess the fatigue was my biggest thing. Which, I mean, none of this directed my mind toward even the tremors in my hand or the arm not swinging. I mean, there was not even a thought in my mind that this is what it was. I didn't know what, I had no idea that where any of this was going. So I didn't have any, not that I can recall, maybe mood changes, probably developed a little bit more anxiety than I ever had dealt with before, but didn't realize that until later, reviewing and kind of going sidestepping backwards.
Yeah. And, you know, anxiety is so common, you know, who would think that it's necessarily a pointer towards Parkinson's disease? Yeah.
I mean, the way I found this was because I had had cervical surgery the year before. And so when I started having some other issues that was related to my right side rather than my left side, that was when I was sent on to a neurologist, and that's how it was found. And so I had no idea. I just thought it was because of a sports injury or something I had done, you know, that was related to that cervical surgery. Had no idea.
Yeah, we hear that a lot, that people get their neck looked at or maybe think it's a rotator cuff injury if their arm doesn't move correctly. Sure, sure. Mary, let me follow up on this one more time, of you kind of knowing a lot already before you were diagnosed. Do you think in hindsight that helped you in terms of knowledge empowered you, or did it make you even more anxious because you already knew almost too much?
Well, I would use the term I was disheartened because listening to the treatments that were available 20 years ago, there wasn't a lot. There were things that were being debuted that now are more mainstream, but they were very early introduced then. So I think that disheartened is how I felt knowing what I knew about Parkinson's. But once I was diagnosed and learned that exercise was something that was extremely helpful, could slow the progression, then I've always been active. I've always exercised throughout my life. So that was something easy for me to just continue and make sure I was doing everything I could with that in that regard.
Mm-hmm. And we'll definitely come back and talk about exercise more because it is, like you say, so important. Let me get Lynn into the conversation here. Lynn, you were in your early 60s when you noticed a left-hand tremor in your case, and you were diagnosed. Now, after your Parkinson's diagnosis, let me ask you, how you handled that for friends? Is my microphone off? My microphone just died on me, so thank you for sharing your microphone. Is this one back on? No, it's not. Okay. So let me come back to Lynn. So you were in your early 60s, you had a left-hand tremor, you got this diagnosis, Parkinson's disease. What I would like to hear from you is how you handled that in terms of sharing that information with your friends or family. You know, some people think, I'd rather keep this private and not like, you know, tell everybody, and maybe they're hiding their tremor, and other people feel more comfortable just putting it out there. What was that like for you?
Well, about 2 years before I was even diagnosed, my friends would look at me and say, okay, your hand's tremoring, what's wrong? And I'd tell them, oh, nothing. The doctors say it's just a benign tremor. There are, you know, all kinds of tremors. It's not anything, nothing to worry about. It took 2 specialists who had noted in my records previously that my tremor was there, and again asked at 2 different times what I was doing about it, and again told them the story. I had gone to my physician, we did some cursory testing, he told me they were benign, so I'm not worried about them. And each of them said to me, I think you need to see a neurologist, which kind of scared me, but I said, It's nothing. So finally, I did get to a neurologist and I was diagnosed, which didn't make me very happy. But when it came back to my friends and they'd say something, okay, guys, you're right. There is something wrong. I do have PD. And I just went on that way. And anyone I meet now, if they notice that my hand is tremoring or something's going on, I'll just tell them straight out, I have PD, and that's it. And we just go from there. I never hid it. I see no reason to, but that's my personality.
Yeah, and everybody, of course, brings their own personality to that. How did the two of you handle that, Virginia? Did you share?
Well, with a very supportive family and friends, yes. But I have to admit, it's taken me a little bit longer to kind of put it out there, and I was pretty strong at trying to hide it in the beginning, but now it's if it becomes evident to if somebody asks me, I've gotten better about accepting it. It's definitely helped me kind of move along with it and get past. It just took me a while to get where I was comfortable with, hey, I have it and I just have to deal with it, and I have to try to beat it as best that I can. But I still don't put it out there, but I've got a large friend group and a large family that has been very supportive. I just felt like it wasn't really a need to get to the outside area, and I was just hitting 50 when I was diagnosed, so it wasn't exactly something that
Were you
I was
trying
newly
to avoid
divorced and
yeah.
hitting 50, and
Were you trying to
exactly what I
avoid
wanted to put out there.
a label that would label you as
Yeah.
sick or something like
Yeah.
that?
It is, but I'm like I said, I've worked to get over that
Yeah.
and dealing with that part now.
Yeah, it's a process. It's a
May
process.
It is.
I interject?
Yeah, please, Lynn.
I don't go out there to just any old stranger.
No.
It's got to be somebody that I know and that I have a relationship with, that I feel comfortable with. But with that in mind, they've been supportive to me by, if I'm on the golf course and they know I'm having a little trouble, come on, Lynn, you can do this. So they see that I hesitate over my swing. They're there behind me. I even have one friend telling me I'm not speaking loud enough and giving me the thumbs up. So I have that support after letting them know that, yes, this is what's happening with me. Thankfully, I have that group and I have a great family to rely on as well. But no, I don't go up to a stranger who's talking, answering.
By the way.
By the way, this
Yeah.
is what Parkinson's looks like. No, I don't do that.
And I can identify kind of the same.
Yeah,
Go
yeah.
go about it.
How about you, Mary? How do you handle that?
In the beginning, it was close friends and family, and then now pretty much everyone knows, and I'm very comfortable with it. I think mine was not that admitting that I was sick, but wanting to always have that as a piece of conversation, to just talk about other things.
Right. So I think, one thing that all three of you have in common is your determination to really, beat this thing. And now that you came to terms with it, just turn around and turn it into something good in a way. And so I just wanted to see how everybody dealt with that part. So Lynn, for example, when you were first diagnosed, what you did was enter a research study from the beginning. You were presented with an option, you could potentially go into this research study for a vaccine that might or might not slow down the progression of Parkinson's disease, and you signed up. Can you share a little bit what drove that decision and what your experience has been with that?
Easily. I was being selfish. I was looking for me. And if it was going to help me stop the progression of the disease, which I can't eliminate, then I'm all in. But then I also realized perhaps it will help the next person. And that was part of the reason I all in. I was glad I got accepted.
And what has that experience been like for you?
Everybody's been wonderful. I've gotten great care. I'm certainly being monitored. My my symptoms every so many months. I get evaluated. I know where I stand. I know if I'm progressing or not. It's given me some confidence that, okay, it's not overnight that this is going to happen where my symptoms will get worse. I don't know what my future has in store. I don't know how long and if I will progress. I'm not holding up. That's part of my problem. It's not speaking loud enough. But everybody's been great. Dr. Hinton obviously got me involved, and I can't be in a better place.
Well, we're really glad you're doing the research. Of course, we're benefiting the whole Parkinson's community, and you've done research as well with us, Virginia. So, but you've also mentioned before that one element that really helped you deal with your Parkinson's is your family network. Can you describe that a little bit more? What that means to you?
It's huge, and I've always had a very close family, very supportive, and it's easier to work through things and get if you're getting the encouragement from people. You're doing great, you're doing the right things, you're seeing the right doctors, keep on, I've got several of them. I mean, I got one friend that just periodically, did you take your medicine in the middle of the day? 'Cause she knows how I am. If we're ever anywhere together, it's the first thing she says, have you taken medicine? And which is good. I mean, in the beginning, it was just like, leave me alone, but you quickly realize that just those little bit of things, just, like my mom, how you feeling today? It's not, she's digging at me. She just wants to know, how do you feel? How you feel this week, or whatever. It's support, whether it's from family or whether it's from the doctor's staff or whether it's from good friends or whatever. I mean, we all can't deal without good support, and it certainly helps the anxiety.
Right.
And it pushes you to do more.
Yeah.
You don't want to fail them. You've already told them you're going to beat it. You're going to take care. Can't beat it. I get that part, but to some degree. So you've told them that. Now you have to keep after it.
Live up to your expectations.
You gotta live up to it.
Yeah, that's great to hear. And Mary, you've done, similar. What you told me before was you've kind of not just only relied on your family circle, but you've built this circle of kind of exercise friends, other women with Parkinson's disease that you exercise with. And that kind of brings the two together, the support system, but also what we said we would come back to, which is the value of exercise to women with Parkinson's disease. And one thing you are doing is the Rock Steady Boxing program, which is this community-based, high-powered kickboxing program specifically designed for Parkinson's disease. Now, boxing might not be the most intuitive thing for kind of women our age to be pursuing as an exercise. Maybe many of us have done yoga or Pilates, but probably not boxing. What was that like? Did you have any hesitation of joining that program, and what has that given you?
I did hesitate because as I said, have always been active. So I've lifted weights, I do yoga, I do aerobics every day. So I do a lot of exercise, but I kept asking, what is the difference between Rocksteady and what I'm doing? And so the two things that I could come up with were, one, that there's something about the connection between your fist and that bag that helps the brain. And there's something about the mental exercises that you sometimes do while exercising during a Rocksteady class. And that's like multiplication facts, or naming the capitals of states, counting backwards by threes, whatever that might be. And so I've definitely added that to my routine weekly. But the surprise for me, because I'm not really a joiner, was the camaraderie of the people in that group. People have said that before, and it's like, yeah. But it is. They just welcome you in there. And the women especially have invited me into a virtual meeting that during the pandemic time. And that's just been such a rewarding outlet, and they really teach me how to live.
I'm so glad to hear that you're able to keep that connection up during the pandemic, because it's been so difficult for many of us, you know, Parkinson's or not, to stay connected and to stay active. So that's great to hear, and I'm glad you're enjoying the boxing program. And Lynn, you're doing that as well, right? You're a boxer also.
Yes, I am, and I would never think I'd be hitting a bag, but I love it. And when I'm not there, I do miss it. I find that if I'm having a frustrating day, hitting that bag is the best feeling you can get rid of that frustration level. And you spoke of camaraderie. Absolutely. We've almost become family. You know, we all walk in with some of us on better days than others, and we're there to, come on, you can hit that, or you can do another 10 push-ups or whatever. Absolutely don't want to miss it. And it was hard missing the 5 or 6 months that we had the gym closed because of the pandemic. You know, I walked and did things at home. Just wasn't the same.
Yeah, it's not the same, right? But, you know, luckily you were able, so Lynn also plays golf, and she has other hobbies, she sews. And let me bring this one factor in. You're doing all that without actually taking any treatment for your Parkinson's symptoms. So Lynn is not taking levodopa or anything like that. She's in the trial, but that's not a treatment for symptoms. Tell us a little bit of what drove your decision not to treat your symptoms now, and how do you push yourself to, you know, still do everything despite symptoms?
Well, my symptoms are probably not as severe as maybe some others. I don't find that they interrupt my daily activity. They don't make me stop doing something that I like to do. So as long as I have a longevity in the family, it doesn't mean that I'm going to be out there, but my dad was 101, my mom was 95 when they passed. And so I know the family longevity, and if I'm going to be on medicine all of this time, which will be about 20 more years, I just felt that side effects would be an issue, and the more I needed it, the more, you know, I'd have to increase. So I chose not to take medication as long as I can stay off of it.
Yeah. Now, and that is also a personal decision, and, you know, at any point when you're ready, we're ready. But yeah, some people go that way. But you have, you know, you've just stayed so active despite everything. I just admire that about you, and wanted to ask Virginia, you alluded to the fact a little bit ago that maybe your friend needs to sometimes remind you, have you taken your medicine? It made me think that maybe you're not a person who loves taking medicine either. How did you come to terms with, I got to take these pills and on time?
Well, I guess after getting down here and with Dr. Cooper, you know, just going through that whole strenuous day and realize, I mean, it was so evident that, you know, when I was doing all these tests and everything, you know, and I had read up on some of this before I even had gotten down here. And, you know, I realized that before even getting here, I was going to be put on something. I didn't think I would be thrown on something that strong right away, but I did. And, you know, I don't like taking medicine. But at that point, I was willing to do anything because, you know, I guess I was still in shock for one thing, that I was just thinking, oh my goodness, just give me anything, you know, whatever I can do to stop it. And, you know, as far as with the levodopa, you know, I immediately, it was just a matter of a couple of weeks that I felt a huge difference. Number one, my fatigue it definitely decreased that, and that was huge. And then it started to work on the other parts of it, but the fatigue.
So it made you feel more like yourself again?
Yeah, it did, because I was struggling. I didn't realize why. I was working so hard to feel better. And, you know, at that time I was just going. And I'd come home from work and I was just, I would almost feel sick because I was so tired. But of course, I'm just that type. I got
Yeah.
to keep going. And so I would keep going, keep trying to, keep doing things. And so, when she mentioned the medicines that she was prescribing and what they should do to help me, I was all in for that.
Yeah.
I definitely wanted to try it. So
Well, I'm glad it's working for you.
yes, it is.
Let me ask you, Mary, taking medicine, having a diagnosis, and you take medicine as well, has that affected your self-image in any way as a woman to, be relying on something external in a way and having a chronic disorder? Is that something that makes you look at yourself differently or not at all?
I think it did, because it almost felt like I had to have this pill, which was a piece that was missing for me. But now I've just come to accept it that a lot of us have to add things to our lives to have a better life, especially as we age. And this is what I have to do.
So it was a process that you worked through. And
Yes, yeah, absolutely a process.
Yeah. So Lynn, now that you've lived with Parkinson's for a little while now, and we've talked a lot about Parkinson's things, is there one thing that you wished you had known when you were diagnosed that you know now that you could share with others?
That's tough. I really can't pinpoint anything in particular. From what I know now, it would not have changed the diagnosis. Don't think it would change how I handled it. So I guess the answer is no to that.
Yeah.
I mean, one thing I have learned, that it's such an individual disease that it strikes everybody differently. And I always thought when you said Parkinson's, it was one blanket word, and it was just one disease and didn't have all of the different effects that I've learned for different people. So I guess maybe that's the answer.
Yeah, so maybe the answer, like you're saying, is, now you know how individual it can be. It doesn't have to be one label for all. It's many little labels, if at all. Yeah. How about you, Mary? And anything you think you should have known, maybe, or?
Well, I would say that there were two things that were relieving to me after having the diagnosis. And one is that once I met the medical staff, they not only were what I expected as far as knowledge and expertise went, but they also allowed me to have time and space to learn about Parkinson's. And I think the other part of that is the women that I've met with Parkinson's, especially that rock steady boxing class. They have helped me live with Parkinson's.
How about on your side, Virginia? Anything that you think would have helped you if you had known it then?
Well, I guess my immediate response to come down here to MUSC was because I didn't wait to do that. It's hard for me to say what would I have done different, because I feel like the steps that I took were the right ones. Just general knowledge, just like Lynn said. I heard the word Parkinson's, and I put myself in one category, and it's so broad. Of course, everybody in my network, they've been educated. They've all read up on it. They've all, but that's the thing is, there are so many types
Right.
out
So
there.
It's really, I guess what you're saying is, we just need to, as physicians and as a general, we just need to educate people more. You've educated your little small group of friends and family. But it's really our job to do things like we're doing today to get the word out and really, educate people about Parkinson's, not just patients, but also their families and caregivers and the general public. So I think those are great points you're making. what we're doing right now is we're transitioning to the next segment of this discussion. And what we're doing is a question and answer session. So the way that will work is you can type in your questions into the chat function of the Zoom call. And I will then share with our three panelists here and also with Dr. Cooper what your questions are. And then they will give you the answers. If your question is not answered right now, there's another opportunity to ask these questions at the breakout session. So don't despair, we might get around to them in the smaller group setting. But we would like to get started with this part of the program right now. So the first question from the audience is actually to our three women panelists. And the question is, are any of you three still working? And if so, how do you manage that and what are the challenges?
I'm retired, so that's.
Lucky you. How about you, Virginia? Picking on the youngest here.
Yes, I'm still working. I've got a construction company and I also do real estate. And some days it can be challenging, but I've learned to listen to my body, which is my hard head. It took a while.
Mary, you're retired?
I am retired. I do volunteer for a couple of organizations, so it's maybe adjusting my schedule around the volunteer opportunities so that I feel my best during those times.
So learning to listen to your body and
Mhm.
schedule activities around your best times. That's
Yes.
something that's really, really important, works for many people. Next question is for Dr. Cooper. And the participant would like to know if there are any studies that tell us whether medications should be dosed differently for women compared to men.
So there's actually not any studies, but I will tell you that those of us who are Parkinson's disease experts, we know from our experience that women are more likely to need lower doses of medicine and more frequently get those dyskinesias and wearing off. So it's more often that with a woman, I'll keep the doses low and really change the timing of the medicines. And I may even have a lower threshold for recommending adding on an additional medicine that I think will help buffer against those risks of those side effects. So while we don't have any pure guidelines or research, that's something that when you become a Parkinson's disease specialist and you're seeing Parkinson's disease patients, it quickly becomes apparent how we do adapt our medication schedule for women.
Next question back to the three panelists, which is, how do you manage fatigue? Virginia already mentioned that the starting medicine helped her fatigue, but maybe some other strategies as well from you. And hold your microphone up.
Yeah, sorry. Again, it took me a while, but learning to listen to my body, and I've just always been one of those push through type people, and I've realized that it's not doing me any good. Eating right is huge. Eating on schedule, which is something I've had to learn to do because I am a meal skipper and things like that, staying hydrated. And, exercise is huge. So if you're fatigued, you exercise lightly. But if you have got good energy, then do what you can, just don't overdo it. But I've learned the hard way that even when I'm tired, there's certain things that I need to do, even if it's just getting on the floor, doing stretches, or getting on the bike and just go for a leisurely ride. It generally helps, if not right away, at least the next day.
Lynn, any strategies on fatigue if you're out on the golf course?
Yes, that's because I'm swinging too much. Virginia mentioned fatigue and dealing at work, and I've noticed lately for myself that I've been fatigued, although I sleep well and I get a good 8 hours of sleep. I've noticed around 2 or 3 o'clock, I'm beginning to get tired. If I sit down and let myself be tired, then I'm not good for the rest of the day. But if I get up and I walk around, or I do some stretches, or I do something to keep me motivated in a sense, then I'm good for, and then I get a second win and I'm good for the rest of the night. But yeah, again, it's a matter of learning what your body is and how you read it and handle, what you can do, adjusting.
Right. And the next question here actually, I think, is closely related to the fatigue question, namely, are there any nutrition-based, or is there any nutrition advice you can give from your own experience? What foods kind of energize you or kind of hurt you? Mary, why don't you take that one?
I have found that animal protein is exceptionally hard for me to digest. So I just limit how much I eat and eat a lot of plant-based proteins, knowing that I've also got to make sure I'm getting B12 and iron and other things that animal protein provides that plant-based protein does not. And I just eat smaller meals throughout the day, or at least a decent snack that it's very nutritious and rich in nutrients.
Virginia, do you follow any specific diet, or how do you watch out for those things?
Well, again, during the daytime, I'm bad about being a meal skipper. I'm getting better at that. But, and I go through times where I get on this real leafy green and fish regimen where I just I can stay steady on it for about 2 weeks and just, I don't know, you can really only do it for about 2 weeks, because then it's just kind of like the overdose of the omega-3 and everything else begins to catch up with you. But it just kind of re-energizes. I don't know if it's getting rid of the bad cells, so to speak, but it seems to work. So if I'm really feeling like I can't catch up, then I make a point of changing my diet. Other than that, I'm not real good at it.
Okay. Next question is coming a little bit to the question, kind of, why me? Why did I get Parkinson's disease? And the audience participant would like to know if any of the three of you sought out any genetic testing, or maybe 23andMe, any of those commercially available test kits, and what your experience was. Mary, you had obviously a family member, your mother with PSP, but that didn't make you want to get tested in any way.
No, it did not.
Yeah.
No,
No,
not for
no,
me either.
no, all across.
Doesn't change the situation.
Okay.
No.
Is that, Dr. Cooper, bringing that question to you? Is if I'm your patient and I say to you, should I get tested? What would be your answer?
So if, first of all, I don't really recommend the 23andMe or the commercial genetic testing, because it tends to be rather incomplete. And so it offers answers that may not actually be true when it comes to the specifics of Parkinson's. It depends a lot on the individual. I will say one really exciting development in the field of Parkinson's is that 2 of the most common genetic changes that are associated with Parkinson's have medications coming out that are targeted at those genetic changes. So previously it was not something that we really did quite often, but now there's actually a international study that's designed to send off very thorough testing for Parkinson's genetics. And given the potential that it may actually change the treatment, I recommend it to everyone. It's also through the clinical trial, it's free. That used to be a very large barrier as well, that insurance would not cover genetic testing for Parkinson's. But this is actually a development in the last couple months. Unfortunately, it's kind of started around the time the pandemic did. So the important aspect is that any genetic testing should come with genetic counseling, meaning an expert who can actually interpret the results and tell you what it means. Particularly with something like Parkinson's, where it's far from a sure shot that if you have this genetic mutation that your family members are at risk. So having an expert really get into the nitty-gritty and give you the details as far as what this means for your family, because that, of course, is the next kind of question after we think about you. is incredibly important, and this clinical trial does. So if I will just mention, that is something we're doing here at MUSC. You do not have to be a patient of MUSC to participate, but we'll certainly have information for you to contact our research coordinators if interested.
Yeah, and the Parkinson Foundation also launched a broad genetic study, but here at our center, we are participating in another international study. And so it's just a simple blood draw, and you can get that information that might lead to future treatment options. One important question, we just have a few minutes left, that I want to get in, that another audience member is asking of Dr. Cooper, is you had mentioned, Dr. Cooper, that women do very well with deep brain stimulation as a treatment form. When should a woman with PD consider this option?
Yeah, so that's an important point, because when we hear brain surgery, all of us immediately say no, right? Elective brain surgery seems like two terms that shouldn't go together. But in the world of Parkinson's disease, deep brain stimulation surgery is not considered a last resort or something that you go to when, you know, there's no other options, quote unquote. It's really something that's designed to treat 3 particular symptoms in Parkinson's very well. So and I will say, you should try medicine first, right? Taking a pill by mouth is inherently less risky than doing brain surgery. So that is something, and given that we have more pills options than we used to, sometimes it takes a couple years to actually try all the medications. But if you've gone through the medications with your doctor and you're not getting the response you like, or you have one of the 3 symptoms that DBS treats, then that's the time to seriously discuss it. Those 3 symptoms are tremor that's not responding to your medication, dyskinesias that despite working with your doctor to alter your medication dosing or medications that you're taking are still quite bothersome, and the motor fluctuations, meaning the roller coaster throughout the day of the medicine wearing off. If those 3 items are affecting your quality of life, it is time to seriously consider deep brain stimulation. And likely your doctor will bring it up. If they don't be shy to ask. Is this something that DBS would help me with? They will tell you no if they don't think it's appropriate. We have a very thorough process for evaluating for DBS before we actually send anyone to surgery because of the risks of brain surgery itself.
Follow-up question from the chat to that information was, how do you take care of a brain stimulator during a pandemic? You know, we're doing a lot of telemedicine visits right now. Can you do that through a Zoom call, or do you have to come in? How do you manage that?
Yeah, so I manage it every week. And so it varies. For some people, if they're really having an inadequate response or very bothersome symptoms, we do have them come in, and we are seeing them in clinic to adjust their stimulator. All patients with DBS, regardless of what type or what brand DBS you have, are given a patient programmer, which is kind of a remote control looking device. So over the video visits, I can actually have someone check their own batteries, make sure that their battery levels are acceptable range. And depending on if I've built into their programming the ability for them to adjust it at home, which we do within reason and using our judgment, then I can even have the patient sitting at home adjust their own DBS with my guidance. I usually prefer that I'm consulted before they adjust their DBS, but that's something that we go over pretty clearly in clinic. So we're still doing it quite well. And certainly we're taking care of folks who need their batteries replaced for any reason during this time.
So bringing that briefly back to our panelists here, you know, none of you are in a situation right now, as far as I know, that you would need to consider deep brain stimulation immediately, but just kind of hearing this talk, is that something that you would say never, or is this something you're quite open to in the future?
Absolutely.
Absolutely open.
Yes,
All right, so
absolutely
we're
open.
getting a yes vote. How about the other two?
Yeah, if the motor skills and everything else following were to get that, I would consider it.
So if
I'd have to get
continuous
considerably
success,
worse.
you might just want to consider you. How about you, Lynn?
I probably would consider it if it was my, I hate to say my last resort, but I've tried everything else and I'm having so much difficulty. Yes, if that was all.
Yeah. But, you know, like you're saying, you'd rather be conservative, and that's the same way we are as the doctors. We, you know, rather not do it, but if we have to, this is such a great tool, and we just don't want them to not have the same access that their male counterparts have. So, well, thank you so much for answering these audience questions, and we will try and answer more of them during the breakout sessions. It is now time for a scheduled restroom break. So you all will not miss anything right now if you go to the restroom. And we will reconvene in about 10 minutes with our interactive exercise session that Victoria Wilson from Physical Therapy with MUSC will lead with our panelists and with all of you at home.
Hello, everyone. My name is Victoria Wilson. I'm a physical therapist here at MUSC, and I'm a board-certified neurologic specialist in physical therapy. So I get the opportunity to work with lots of folks that have Parkinson's and Parkinsonisms. So today I'm going to talk to you about exercise, and then we're going to do several exercises together. First, I want to say that exercise is one of the most important treatments for slowing the progression and improving movement in people that have Parkinson's. I like to say that movement is medicine, and it's really true. Movement is truly medicine for people that have Parkinson's disease. Numerous research studies have shown that moderate to vigorous intense exercise can actually slow the progression of Parkinson's and improve brain function, which is a huge deal. One of the mechanisms by which this happens is by promoting release of a protein that promotes healthy, positive brain change. This may improve mood, cognition, memory, and even your brain's control of movement. Not just in people that have Parkinson's, but especially in people that have Parkinson's. So unfortunately, due to COVID-19, many people with and without Parkinson's have been having trouble getting active, staying active, moving around. So I encourage you to adopt my mantra, movement is medicine, and just get outside, move the best that you can, because that will truly help you continue to fight back against PD. So just a quick word on intensity. Before you heard me say moderate to vigorous intense exercise. So this means that you're not just moving at a comfortable pace. You're a little bit uncomfortable. You are unable to sing a song. You're unable to have a full conversation. You are working at an intensity that, if we think about the way that we quantify pain, 0 to 10, 10 being the most, you're working between a 6 and a 9. So 6 out of 10 to 9 out of 10 intensity will get you that brain-changing benefit. So while we're doing these exercises, I want you to think about the intensity that you're working at. I want it to stay pretty high because I want you to get the benefits of the exercise. So physical therapists work with people that have Parkinson's to improve their movement through skill training and devising appropriate ways to teach them to do moderate to vigorous intensity exercise. Today, we're going to do several exercises that I might use in practice. But certainly if you were to see a physical therapist, the exercises would be tailored to you and your problems. So there are many methods of reaching this moderate to vigorous intense threshold. Today we're going to focus on 2 specific types of movement that are often problematic in PD. These are changing positions and rotation. So safety first, I want to make sure everybody is sitting in a stable chair like our panelists are. No wheels, preferably has arms, and is not too soft. Second thing is we're going to be getting down to the floor today if you feel comfortable. So if you have knee problems or feel that your knees may not be comfortable on the floor, make sure you have a yoga mat or a towel. So we're going to warm up a little bit, just in place. We're going to start with some marching. Okay. Everybody stand up for me. Hear me on the mic. All right, so we're just going to start by marching in place, really simple. I want your arms moving really big, your legs moving really big. And if you're up for it, we can do a little jog in place with arms moving really, really big. All right, so the goal is that your heart rate is up and you're feeling like you're moving toward that moderate to vigorous intensity. You're probably not there yet. You shouldn't be. Okay. All right, everyone, I want you to sit down. So everyone find your seats. All right, we're going to start with sit to stands, which is often problematic for people that have Parkinson's disease. So setup is really important here. You should be on the edge of your chair. You're not going to fall off, I promise. And you should have your feet wide apart and underneath you. Not here, but here. All right, so everyone watch me do it one time, and then we'll do 10 together. Here we go. Okay. No hands. They're going down to the floor. Here we go. 1, 2, 3. As big as you can get. Really open up your chest. 4. And don't drop your microphone. Everybody sit down. 5. 6. 7. 8. 9. And 10. All right. We're going to build on this exercise in the next circuit. All right. So our next exercise here, is everybody feeling 6 out of 10? 5 out of 10? Getting there? Okay. Our next exercise is just a little rotation in your seat. So you're going to keep your feet spread wide apart, very wide, and you are going to twist. Okay? Chest stays up tall. We're going to do 5 to each side. Ready? Everyone wide and twist. Very nice. Chest up tall. 2. Good. 3. 4. And 5. Very good. All right, we're going to go to our other side now. Here we go. 1, making sure that you stay with good posture. 2, 3, 4, and 5. All right, stay here and come on down to the ground. All right, everyone get into this kneeling position. I want you to feel the muscles on the back of your body. Make sure they're all nice and engaged. Okay, so we're going to come down to all fours, all right? And then we're going to just push up into this big tall position. Should really feel your glutes working. Okay, here we go 10 times. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. All right, everyone back to their chairs, please. All right, we're going to start our second circuit. So we're building on exercises from the first circuit. The first exercise we're going to do is squats to the chair. So we're not actually sitting fully like we did in the last round. It's going to look more like this. So arms come out really big, and you come down into a powerful squat. If you do not feel that you can do that, you can just do sit to stands again, the same way we did with big motion. Ready? Here we go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very nice. Okay. Back to your chairs. We're twisting again. But this time, we're going to come down to the floor, and we're going to stand up 5 times each side. Okay? All right. So twist to the side. Very nice. Down to the floor. And ready, power through your front leg. 1. Use the chair if you need to. 2. 3. Big step forward. 4. 5. Good. Everyone back to the chair. That's okay. You are our modification model. That's good. Okay. Everyone twist to the other side. Okay. We're coming down to the floor. Weight goes into your front leg. You can use the chair for balance if you need to. 1, 2. Good job, Lynn. 3, 4, 5. Okay, we are coming back to the ground, and I'll show you what we're about to do. Okay, so this is building upon the exercise that we had before, all right, where you're coming from all fours to up tall. We're going to add a rotation component. Okay, so you will go fours, up, punch, punch. Whatever orientation you'd like to be in. I know, I switched. Okay, so every time, 10 of them. All fours, up tall, punch, punch with some power. Good. All right, down, up tall, squeeze your butt, punch, punch. Down, up tall, punch, punch. Wonderful. Down, up, punch, punch. Down, up, punch, punch. Down, up, punch, punch. Down, up, punch, punch. Okay. Everybody back to your chairs. You made it. All right. So I'd like to know, did we get to that 6 out of 10 intensity with anyone? Very good. All right, great. Thank you, everyone.
So thank you so much, Victoria. We will now go to our breakout sessions that were pre-assigned.
Can you hear me, Annie?
You sound great now. Thank you.
Okay, great. Sorry about that. We had Zoom muted. I was talking away back here. Couldn't tell because I had a mask on. Anyway, we're going to do a little flexibility session in between breakout sessions. So first couple exercises are going to be done from a chair. So I want everyone to spread your arms out wide, squeeze your shoulder blades together, and we are just going to twist and hold your shoulder blades back. All right. We're going to come back to the middle and twist the opposite direction. Make sure you're really pushing your chest out and squeezing your shoulder blades together. And back to the middle. Other side again. Chest out, shoulder blades together. Like you're really opening up. Okay? Your shoulder blades should be getting a little bit tired. Okay. Chest out, shoulder blades together, and last time, the other direction. Fingers should be spread as far as they can be. All muscles engaged. Very good. All right. Again, from your seat, you're going to spread your arms out wide and reach down, opposite arm to opposite leg, looking up at your hand. All right. Everyone come up to the middle. Give your arms a break if it needs it. Okay. Back up. Opposite arm to opposite leg. Big twist. And look at your arm up high. Big fingers. Very good. All right. Back to the middle. Arms drop. Arms re-engage. Good. Coming down to your other side. Looking up at your hand. Make sure you're breathing. A lot of people like to forget that. It's very important. Your brain likes that oxygen. Okay, up to the middle, drop your arms, re-engage, and to the other side. Okay. All right, we're going to come down to the floor. We're going to work on a couple of exercises for spinal rotation here from the floor, starting with the lower spine. This is pretty simple, something that you can do in bed before you get up in the morning, just to get your body moving. Your legs should be moving like windshield wipers. Even better if you can spread your arms out wide. All right, the next exercise is more for your upper spine's mobility. So you're going to start from a sideline position, knees bent up, and not laying on your microphone, because that's bad apparently. Fingers spread apart and hands together, like you're clapping. Then you're going to open up wide and look at your back hand. And you're going to close down. This is helpful for rolling, but it also improves the mobility in your thoracic spine, which is between your neck and your low back. The whole time, keeping your motion as big and as purposeful as you can. And switch sides. Again, looking at your back hand, following it with your neck. Okay. We're going to come up to this half kneeling position that we were in before. Use a chair so that you can get the most stretch possible. What you're going to do is push forward so that your leg that is down is getting a stretch in the front. If you don't quite feel it, tuck your tail. You should feel it more. We're going to hold this one. Very good. Switch sides. Remember, if you don't feel it in the front of your leg, tuck, and you should feel more. Really pushing that hip forward, getting a stretch in your hip flexors. These are often what cause some stooping. Okay, we're going to do one more time each side. Switch legs. Remember to push the hip forward and tuck. All right. Okay. And that's been our stretching intermission. Everybody can proceed to your next breakout session.
All right, everybody. I don't know about you, but I certainly learned so much today, and I really enjoyed my morning. But, you know, this was for you all, not for me, so I hope the same is true for you. So let's just summarize a few things that we have learned today. And if Dr. Turner would help me with advancing my slides, then I could certainly do that. But, you know, one thing that I want you to take home, kind of the main message from today, is that you're not alone with this, and that we are certainly here to help you with everything, and that there are other women who are in the same boat. Arrow up. Okay. And, you know, none of this would have been possible without our sponsors. So thank you again to Amneal, Acadia, Supernus, and Kyowa Kirin. You made all this possible. So summarize what we learned is that women are certainly different, right? In the way that Parkinson's disease symptoms manifest. You know, we might experience more pain, more dyskinesia, and we have maybe more non-motor symptoms on the mood side, the cognitive side. And we're also more interested in alternative treatment options. We might be less likely to receive some of the more advanced therapies like deep brain stimulation, but we would benefit from them if we were to seek them out. And sadly, we are less likely to be cared for by a Parkinson's specialist and even to access any medical care for Parkinson's. So there are certainly a number of things that need to be changed. So what I want us all to kind of promise ourselves, and especially you to promise yourself, is to please let your doctor know if you're struggling with anything related to Parkinson's, and especially with any mental health concerns. If you were part of the mental health session today, the breakout session, you've learned that depression and anxiety are so common, and we have effective treatments. We just need to know if you're suffering from any of these symptoms. You need to take care of yourself. You need to eat well and sleep well and exercise and delegate things to others. We can't just always do it all, even though we sometimes want to, but just go ahead and just unload yourself a little bit. And, you know, if you were part of the intimacy and communication session, you certainly heard Dr. Gila Brana say it, you know, more than once. Spend time on seeking out not just any communication, but honest communication. Tell people how you feel. Your emotional, your physical intimacy, they can really increase your happiness and your well-being and how you feel about yourself. So here are 2 to-do lists, okay? So first of all, this is on us, the healthcare providers. What do we have to do to make things even better for women with Parkinson's disease? We have to make sure that our research addresses the issues that women experience. It needs to be relevant. We need to be able to communicate issues clearly to women. There can't be some, you know, invisible barrier so that a woman feels she can't talk to her doctor. That should not be existing. We need to be very clear with every woman patient about the goals of treatment. We want to be there to help your caregivers be better caregivers. We understand it's very hard for people to help other people, and not everybody is born with that gift or talent. So here at MUSC, and with help of the Parkinson Foundation, we've put together a caregiver support group to teach caregivers the skills they need to be better partners in your life. We just, in general, need to provide tools that help women with Parkinson's disease gain the knowledge and just live with a higher quality of life, with the highest quality of life that they deserve. But this one is kind of on you. We need you to help us help you. So what we are suggesting as an action item from today's meeting is that we unite the women in the Carolinas to potentially build a women-only support group around the state. And we can start this virtually, and hopefully at some point we'll be able to get together again in person. We need you to speak up and tell us more about women issues. And we could do that in some smaller in-person focus groups now with either MUSC or the Parkinson Foundation, but we'd love to hear from you. We want you to participate, not only in these focus groups and support groups, but also in research. You know, it can't be that women are underrepresented in the progress that we all need to make. We need you to be part of that, and we'd love to include you. And, you know, we want you to seek out other women and spread the word and encourage them to do what you've done, which is seek out more knowledge, seek out specialty care, and ask about what therapy is the right thing for you. So if we can do all that, if we can do our to-do list and you do your to-do list, I think we've brought about a lot of good out of this meeting today. Now, outside of all these women endeavors, please keep in mind there are a lot of very meaningful virtual events that the Parkinson Foundation has put together with their PD Health at Home initiative. Every Monday, you can enjoy the mindfulness events. On Wednesdays, you can practice wellness. And on Fridays, you're going to work with your fitness Fridays. So this is a great way to stay engaged with the foundation and with other people who have Parkinson's disease. So please take advantage of those opportunities. So finally, thank you so much for attending and sharing. Thank you so much to our 3 panelists and to one of the husbands of our 3 panelists who very patiently sat outside the meeting room the entire time this morning and gave us the female privacy that we really needed today. So that was just an example of how we all are enjoying our family support systems. So have a great day, everybody, and please stay safe.